Hey everyone, in this video, we're going to break down the latest data on conservative, meaning non-surgical management of urinary tract rupture in dogs and cats. We'll compare a few recent studies and walk through a practical decision-making algorithm you can actually use in real life. Now, historically, the words urinary tract rupture were pretty much synonymous with prep for surgery. And that's not just anecdotal, it's backed up by data. Multiple studies show that the vast majority of these patients undergo surgical repair, anywhere from 75% to 95% of dogs and cats, depending on the paper you read. But here's the thing. We now have a growing body of evidence showing that selected cases can actually heal with medical, or what we call conservative management. This is typically handled by placing a catheter or drain to direct the urine away from the lead, a process called urinary diversion, which simply means rerouting urine so it doesn't build up where it shouldn't, while the body has a chance to heal. A recent 2025 retrospective study out of the Royal Veterinary College in London looked at this specifically. They documented 40 cats and 12 dogs with confirmed urinary tract rupture that were successfully managed without surgery. Now, it's important to note, this RVC study only included animals that survived and were managed conservatively. So it doesn't tell us how often conservative management fails, but it does show us what's possible. In this case series, the most common causes of urinary tract rupture in cats were urethral obstruction and catheterization in 17 out of 40 cases, followed by cystocentesis-related injuries in 14 cases. Only 5 cats had external trauma not related to iatrogenic injury. For the 12 dogs they included, the most common causes were cystocentesis, external trauma, and recent urinary tract surgery, each responsible for 3 cases. So, many of the cases in this study were iatrogenic. In other words, the rupture was caused by a medical procedure or intervention. That's different from previous uroabdomen studies where external trauma, like getting hit by a car, was one of the most common causes. For example, earlier studies reported that trauma contributed to 30 to 56% of uroabdomen cases. But in the RVC paper, trauma accounted for just 8 out of 52 cases, around 15%. That's a really important detail to note when applying the results of this study on your own patients. It could be that external trauma cases weren't attempted to be treated medically from the outset, and therefore they were not included. Or maybe they started conservatively but failed and were excluded from the study. Either way, it's something to think about. Let's move on to the anatomical locations of rupture and how they were managed conservatively in the RVC study. The 2 most common sites of rupture were the bladder and the urethra. 19 of the 52 cases had bladder rupture. Of those, 16 were managed with urethral catheters. In addition, abdominocentesis was performed in 3 cases, and a percutaneous wire-guided peritoneal drain was placed in 5. 3 other cases were managed with peritoneal drains alone, and one of those also had a cystostomy tube placed because they couldn't pass a urethral catheter. For bladder ruptures, urethral catheters were typically left in for a median of 3.5 days, ranging from 2 to 6 days. Peritoneal drains were left in for a median of 2 days, ranging from 1 to 5 days. Now, let's look at the 25 cases of urethral rupture. 8 were managed with urethral catheters alone. 6 were managed with cystostomy tubes alone, and 10 were managed with both a urethral catheter and a cystostomy tube. Out of the 18 urethral catheters placed, 11 were passed the usual way, from the outside in through the urethra, also known as retrograde. The other 7 were placed during surgery by guiding a special flexible wire from the bladder outward through the urethra, also known as antegrade, using a small incision in the bladder wall. For these urethral ruptures, urethral catheters were left in for a median of 6 days, ranging from 2 to 7 days. Cystostomy tubes were left in longer, median 14 days, ranging from 5 to 58 days. Again, this study only included successful conservative cases, so we can't draw any conclusions about superiority compared to surgery. But let's bring in 2 other retrospective studies to help us compare. Hornsey's 2020 study looked at 53 cats with uroabdomen. About 25% were managed medically with a 62% survival rate. In the surgical group, 78% survived. The difference wasn't statistically significant, but the sample size was small, and we can't rule out false negative results or type 2 error. Then there's the 2018 Grimes study, which looked at 43 dogs with uroabdomen. Only 6 of the 43 were treated medically, and 37 had surgery. 5 out of 6 dogs managed medically survived, compared to 29 out of 37 dogs that underwent surgery. 1 dog with a urinary tract rupture of an unspecified location had a urethral catheter in place for 4 days. However, it developed a uroabdomen 3 days after the catheter was removed. Instead of going to surgery, attending clinicians replaced the catheter for another 8 days, and the dog went on to recover. So even if medical management fails initially, it may still succeed if you give it more time. Again, none of these are large studies, but put together, they suggest that conservative management can work in both species when the conditions are right. So that brings us to the million-dollar question. How do you decide who is a good candidate for conservative versus surgical management? Short answer, we don't really know. There are no prospective studies directly comparing the 2 approaches. That said, here's my own approach, and it is based on personal experience and the literature review. Step 1. If you have an unstable pet with suspected urinary tract rupture, don't rush to surgery. Stabilize first. Treat the shock, hyperkalemia, metabolic acidosis, and any coexisting electrolyte derangements. If there is a large uroabdomen, perform abdominocentesis or place an indwelling abdominal drain to speed up correction of metabolic abnormalities. Step 2. Next, I want to confirm the diagnosis and rule out septic uroabdomen. To do that, you'll need to do abdominal fluid analysis, including cytology, effusion to blood, creatinine ratio, and potassium ratio. If there is evidence of septic effusion, I would send this case to surgery. Unfortunately, we just don't have data yet proving that antibiotics and urinary diversion alone are enough to manage septic uroabdomen, which in theory is possible, but will be hard to justify ethically. Regarding those ratios, traditionally, we consider an effusion to blood creatinine ratio greater than 2 and a potassium ratio greater than 1.4 to support a diagnosis of uroabdomen. In the original Schmidt study, a creatinine ratio greater than 2 showed 86% sensitivity and 100% specificity, while a potassium ratio of greater than 1.4 had both 100% sensitivity and specificity. In the more recent 2018 Grimes et al. Study, the effusion to serum creatinine ratio was supportive of your abdomen in 26 out of 29 dogs, or about 90%. In contrast, the potassium ratio was only supportive of your abdomen in 8 of 14 dogs with confirmed urinary tract rupture, which is roughly 57%. Of the 6 dogs with confirmed uroabdomen and a potassium ratio below 1.4, 4 dogs still had a creatinine ratio above 2. The other 2 dogs had neither ratio supportive of uroabdomen, but both were later confirmed to have urinary tract rupture at surgery. So these ratios aren't perfect. I would recommend measuring both of them to increase your accuracy. And remember, even both negative ratios don't rule out rupture. You may need contrast imaging or even surgical exploration to be 100% definitive. Step 3. Once you've stabilized and confirmed your abdomen and ruled out sepsis, identify the leak location. It could be the kidney, ureter, bladder, or urethra. Your urethral tears especially may not cause free fluid in the abdomen. In the RVC study, 6 animals with urethral tears had scrotal, preputial, perineal, or pelvic limb swelling, and 1 cat even had an abscess in that area. So, if you suspect a urethral tear, but there is no free fluid, think soft tissue swelling instead. Diagnostic imaging used to locate the source of leakage may include retrograde cystourethograms, excretory urograms, or CT with contrast. Knowing the location, bladder versus urethra versus ureter versus kidney, is key to choosing the most optimal management approach. Step 4. Once you've identified the location, ask yourself 3 following questions. Is the defect small and likely to seal? Or is this a large and complex tear like complete bladder transection or devitalized tissue? Is my patient stable enough to go under general anesthesia if surgery is a preferred approach? In general, small iatrogenic tears, like from cystocentesis, may do well with medical management. Large or devitalized ruptures usually require surgery. Unstable patients may need at least short-term conservative care, even if surgery will be needed later. Interestingly, an experimental study by Burrows and Bovey in 1974 found that 3 out of 14 dogs with surgically induced 3 centimeter or about 1.2-inch bladder incisions healed spontaneously without any treatment. So in theory, even large bladder defects may have the potential to seal on their own, suggesting that the scope of conservative management could be broader than what current clinical studies capture. Step 5. Discuss pros and cons with the owners. Conservative management is less invasive and often faster to initiate, but it may mean longer hospitalization. That can be just as expensive or even more expensive than a one-time surgery and early discharge. That said, urethral tears, especially in cats, are often best managed conservatively, as surgical access to the intrapelvic urethra is challenging and unlikely to provide superior outcome. Step 6. If you choose medical management, here's how I break it down by location. Bladder rupture. Place a urinary catheter with a closed system. Add a peritoneal drain if there's significant leakage and your abdomen. Alternatively, you can also perform a single abdominocentesis without an indwelling peritoneal drain if leakage has stopped. For the peritoneal drainage, I personally prefer small bore wire-guided catheters similar to Mila chest tubes. However, other options are available. For urethral tears, First, I would try retrograde catheterization. If it fails, antegrade catheterization can be attempted as well. If that fails, a cystostomy tube can be considered to establish urine diversion. In the RVC study, 11 of the 18 urethral catheters were placed retrograde, while the remaining 7 were placed surgically using a hydrophilic weasel wire passed antegrade from the bladder through the urethra via cystotomy incision. Median urethral catheter duration was 6 days, and cystostomy tubes stayed in for a median of 14 days. 17 of 18 cystostomy tubes were placed during surgery. With respect to ureteral or renal pelvic ruptures, these can often be managed with an indwelling peritoneal drain alone, or a drain plus urinary catheter to reduce the hydrostatic pressure within the bladder. Step 7. Maintain the diversion, monitor, and watch for complications. Before removing devices, recheck imaging, ideally a contrast study to confirm leak resolution. If there is still leakage, continue diversion or consider surgery. When attempting non-surgical management of urinary tract rupture, there are 2 main complications to watch for. First, urinary tract infections, especially with urethral tears and long-term catheters. In the RVC study, 14 of 22 patients without pre-existing UTIs developed infections, including 12 of 15 urethral tears. We know from Bubanik et al. That urinary tract infection risk increases 27% per day of catheterization. So duration really matters. The second common complication is urethral strictures that typically occur in patients with urethral tears. These occurred in 11 of 25 urethral tear cases, 44% in the RVC study. 9 of these patients underwent urethrostomy and 2 were euthanized due to decline surgery. The median time to diagnosis of urethral stricture was 12 days. So, at discharge, warn the owners about this possible complication. And if a patient with a previous urethral tear develops stranguria or incomplete urination, you may need to get a contrast urethrogram to rule out the stricture. So, what's the bottom line? Conservative, non-surgical management is a valid, evidence-based option for urinary tract rupture in dogs and cats. It may avoid surgery in select cases, especially when patients are unstable or lesions are small and potentially caused by iatrogenic trauma. Outcomes are comparable in some studies. However, you've got to watch closely for complications and remember that no definitive studies exist to document its non-inferiority when compared with a surgical approach. All right, thanks for tuning in. If you want a visual walkthrough of percutaneous cystostomy tube placement, check out the other vet input video right here. See you later. Bye.